Good afternoon, and welcome to A Comprehensive Approach to Setting Your Mobile Strategy, a webinar tweet chat combo from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I'll be your moderator today. We are having a simultaneous tweet chat hosted by Kate Campbell, our managing editor and director of social media. You can participate in the tweet chat on your phone or in a separate browser by using the hashtag HSCIOchat, and you can simply view the the tweet chat in the media viewer panel on the right-hand side of your screen. Other WebEx panels we'll be using today would be our Q&A panel. So if you have any questions, type them into the Q&A box in the lower right-hand corner of your screen. Leave the default set to all panelists and send those in as they occur to you. We will take them later in the program. And you could download the deck by using the URL on your screen. It's on the bottom of some of our slides, and it will be sent out in the chat box. Just so you see how we're going to spend our time today, we're going to have a joint presentation from Neal Ganguly, VP and CIO at JFK Health System, and Ken Kleinberg, Senior Healthcare Technology Strategist. And then we're going to have some time for our Q&A at the end. So without further delay, I'm going to turn it over to our speakers. Ken, I think we're going to start with you.
Thank you, Anthony. And hello, everyone. Ken Kleinberg here, and welcome to our joint webinar, Neal Ganguly and I, on a comprehensive approach to setting your mobile strategy. I'm just going to show you a picture of Neal and I. We've been collaborating on health IT for years, and the work that went into this webinar started in earnest a couple of years ago, where Neal frankly challenged me. I was at the advisory board at the time regarding all the different possibilities and opportunities for mobility in terms of, well, how do you decide? How do you see where to begin? There are almost an unlimited number of opportunities here, but everybody's got constraints with their budget, with time frames, and so forth. So we started a research program to talk to some of the leading health systems in the country about their mobile strategies, trying to piece together what the essential components were. And Neal and I also had the opportunity to present on this topic at the Chime Fall Forum last year, and also HIMSS earlier this year in Orlando. I'm just going to do a quick introduction of myself, and then I'm going to turn it over to Neal to say a few more words about his background and JFK Health System, and then we'll come back and I'll show you the agenda. So just to say a couple words about me. I've been around in IT actually since the 70s in college, and the last almost 2 decades have been in healthcare IT, mostly as an analyst, but I've worked for some vendors as well. And you can see I was at Gartner as a symbol, where I headed their global healthcare, worked at Allscripts, Health Language, and as I mentioned, most recently at advisory board. And now I'm going to turn it over to Neal to say a bit about his background.
Thanks, Ken. So I've been in the healthcare industry for a little while as well. Ken and I have been fortunate to be able to work together as colleagues in some ways in terms of his work in the advisory board and in some of his other roles as well. I've been in the healthcare industry for over 25 years, in the CIO role for over 18 years. I've been active in the industry as well. I've held board positions at both HIMSS and Chime, as well as in some of our New Jersey-based health information exchanges and some advisory boards. I'm a fellow at both Chime and HIMSS, and speak at industry events throughout the year. Thought I'd also give you a little background on JFK. Although our presentation today is not going to be specifically about JFK, we will talk about some of the things we've been doing there. And just to give you a little bit of a scope, JFK Health System is a community health system anchored by a 500-bed or 498-bed acute care medical center and a 98-bed rehab hospital. And then we've got 500 long-term care beds spread out over 4 facilities, specialty in neurosurgery and neuroscience, as well as a wide range of other organizations and entities you'd expect to see in a large multi-specialty health system. We've got a couple of ACOs running, as well as a growing multi-specialty physician group, participate in a regional health information exchange, and then we have residency programs in family medicine, rehab, and neurology. Ken, why don't you take us through the agenda a little bit?
Yeah, thanks, Neal. So we're going to start out by reviewing some of the drivers of mobility and what's going on with mobile devices, networks, and so forth. And then we're going to get into what I think is the linchpin to all of this, which is the right strategy for mobility, how that fits into the larger organizational approach. Then we're going to talk about basically the build versus buy. We'll look at mobile deployment. We'll look at mobility adoption and measurement, and then we'll take some look into the future. Had literally hundreds of conversations with organizations over the years about this mobile topic, and we feel that this structure that you're looking at in this agenda really is the comprehensive set of topics. There's certainly a lot of detail that could go into every one of these steps, but this, I think, a great way of getting your arms around things. And we're going to start with what these drivers are and how this leads into strategy. So, of course, right down there from the top, awesome new mobile devices from Apple, Samsung, Google. I was a mainframe guy decades ago, and now, of course, what you carry around in your pocket or sleep with, incredibly more powerful than that. Every time you think that there's nothing else they can add, something new comes along, whether it's the beveled screens or the higher display capabilities. It seems like there's no end to this. We were just discussing before the webinar started that Apple looks like they may be coming out with a new version of their watch soon. They've sold, as best I can tell, a couple tens of millions of these already. So it's not just the smartphones, it's not just the tablets, it's also these additional devices. And then just taking you quickly around this circle, locationing services, we've had GPS outdoors, now we're seeing beacon technology being used indoors. The app marketplace, of course, is intense. There's really an app for just about everything in every other part of our lives, so we're looking for the same in healthcare. Those advances in speech recognition, NLP, translation, a lot of this is being fueled by what's going on with artificial intelligence and machine learning, and what used to be a joke a decade or two ago, of course, is now pretty serious stuff. Wearables, not just functional but beautiful, even jewelry-like. This Internet of Things, tens of billions of these. These virtual assistants, I don't know how many of you have like an Alexa, or you're a frequent user of Siri or Cortana, but these have gotten actually quite functional. Just looking at it may be possible to start making phone calls with our Amazon Alexa. Great for my mom. And then the wireless broadband just keeps getting better. I think 4G is pretty terrific. I really can't tell the difference between 4G and my wired internet connection here at the house. And we got 5G coming. So, what is all this leading to? Well, it's leading to a set of expectations that frankly, our healthcare industry isn't quite ready for. So, here are some examples that you might hear in a healthcare setting, such as, well, why do my calls keep dropping in the hallway? Or, I thought we had an app for that. Or, why can't I access all of my Epic or Cerner or whatever on a tablet computer? Or, how come Pokemon Go knows where I am, but the hospital doesn't know where I am? And we're still
one of the
requiring...
key things, really, look at these first couple of slides, is that consumerism is driving this pretty heavily. The fact that we are in an era where it's not us providing the device is coming with the user. And the users are experiencing this ecosystem, as Ken mentioned, of apps and tools and functionality in every other part of their life. Yet when it comes to interacting with their healthcare institutions, we are literally a generation behind, and these generations are being measured in months and years, not decades. And so we've got a lot of catch-up to play here, and that's part of the reason Ken and I originally kind of came together around this topic is, well, how do we come together inside of an organization to present this topic in a way that's manageable and consumable? Right now, one of the challenges is, as Ken mentioned, all these different scope areas around the wheel you saw really creates this massive potential, but it also causes this effect of, you know, you could boil the ocean. There's so much you could do, and mobility can touch every part of the business. How do you go about establishing that strategy? And I think Ken, working with some of his colleagues, has come up with a little bit of a model here. Ken, go ahead. Why don't you walk through that?
Well, yeah. So let's go through these stages of the model, which starts with strategy, and I laid across the top there. You know, are you being opportunistic or one-off on what you're building? Hey, the guys down the street did this; we have to do it too. Are you taking a more formal and prioritized approach? We're going to do this one, and this one, and this one. We're going to build it all on a platform. Or even are you considering mobility to be a transformational approach to your business? So I listed some key requirements there in the leftmost column of this table, and some key questions there. So I'll ask you, Neal, when it came to your strategic plan for mobility, was this something that you developed from an IT perspective? Was this something that was being considered by the executive suite at JFK and even the board? And where does mobility fit there?
Oh, thanks, Ken. It really is interesting because in our perspective, or in our situation, it really was coming from multiple directions. IT had been sitting down and trying to identify what it needed to do with mobile strategy, mobile infrastructure, just simply trying to keep pace with the whole bring your own device versus organizational issue devices kind of scenario, and how to secure the devices, et cetera, to then looking at the customers we have, whether it was the clinicians or executives or others, driving demands for more and more feature function, going beyond just, hey, I want to have my calendar and email on here, but I'd like to be able to access various applications, et cetera. So we recognized there was a need to pull together a strategy, and that was actually when I did reach out to Ken, because we were struggling with the fact that there were a lot of strategic opportunities, but there wasn't necessarily a huge base of proven developed product or solutions out there. And so we kind of worked with Ken and the advisory board to do a little bit of a survey and understand what's out there in the industry. And Ken was able to really find that it's a wide range of what's going on, from community hospitals like JFK, where we are just feeling our way, to and Ken, you can speak to this, some of the larger organizations out there who have actually hired folks away from Amazon and Target and places like that, and are actually working on really intense consumer-facing strategies.
Yeah, right. Providence out there on the West Coast hired Amazon exec, and was all about this ease of use. Darren's working at Cedars-Sinai with the digital front door and so forth. How did you go about dealing with governance? Are there certain individuals that are making the key decisions? Is it more of a group decision? I remember Scott Joslin at Memorial Care telling me that they have the chief operating officer as the nexus of how many of these decisions are made.
In our case, we do have an IT governance infrastructure that's not mobile specific. It's for all IT-based initiatives, and it's meant to link our IT initiatives with the organizational mandates. And so that group actually was exposed to mobility as a topic, and we try to do a lot of education around what the potential and what the impacts could be to expanding our footprint in the mobile environment, and we asked for guidance from them as to how to prioritize this. And then that group helped us reach out through some of our key customer bases, our physicians and others, and we went through a prioritization exercise and came up with a number of use cases that we thought would be a good place to start.
Did you feel the pressure coming more from, you mentioned consumerism and our industry being behind, or was it coming from some of the other health systems that you compete with?
More coming from our clinicians looking for access to tools and resources, and then a lot of pressure around improving communication and workflow using these devices. We had been in the process of dramatically expanding our emergency department, and in that process it was going from a relatively concentrated area where a lot of the communication was done by simply shouting across the room to now an area that's spread over 4 large football field-sized kind of pods. And so we recognized there was an opportunity there for us to perhaps utilize mobile to improve communications. It was one of the use cases we first decided to pursue. And frankly, though, it was an exercise for us in learning because we struggled dramatically. We had a great concept on paper, how to streamline communication using, initially we were using Android-based devices, and we had directory applications on it, and we had secure messaging applications on it, we had VoIP extensions on it, so that in theory all the communication was happening very seamlessly. But in the end, we learned a lot of lessons about what we didn't fully understand about the complexities of mobile devices and the technology limitations of these consumer-based devices being brought onto a corporate network, et cetera. So for us, that first foray into trying to do our own, and we'll talk about build versus buy later, but trying to kind of cobble together our own solution here really was eye-opening.
Yeah, I'm just looking at this large selection of possible use cases and thinking you could decide, let's say at executive level, which ones were important, or you could look to, you mentioned, your clinicians were asking for certain capabilities. Certainly if you do what they want, right, you've got a greater chance of buy-in, especially if they're driving the project, versus if you decide you're going to do something and then require them to do it or follow through with it or make use of it. Were there others here on this slide that you decided to not do immediately for one reason or another, or maybe what might come next? How did you go about prioritizing some of this?
Yeah, in our case, we started simply with things we were doing already around email and calendaring. We looked at scheduling, secure messaging, as I mentioned, and so those were kind of our starting points, that whole unified communication piece. We decided that from the perspective of accessing certain applications and accessing resources, we were going to work with our core EMR vendor on those kind of things. So that was put into sort of a phase 2 type model. But looking at a longer-term vision, telehealth was an area with a lot of interest, particularly since we have multiple ACOs that are operating right now, looking for ways to extend the clinical reach. Telehealth seemed like a great model for that, but we weren't quite ready with tools to pursue that, so we're still kind of evaluating that and trying to figure out how to best implement it. And in the meantime, there are a number of vendors like American Well and others who are kind of getting into that or in that space, and we're becoming more aware of what they can do. What we did decide to defer right now would be some of the real consumer-facing applications and sort of community interaction type stuff that you see there. We're focusing a little bit more on the caregiver-driven needs and wants versus looking at consumer engagement / patient engagement kind of solutions in the JFK plan right now.
Yeah, if there's one trend that I think is exciting is, in the old days we had applications for clinicians like portals, and there were separate applications for consumers, but now we're starting to see some applications that are jointly shared. For example, monitoring chronic conditions where the patient's entering information about their diabetes or their asthma or whatever, and the physician has access to that or nurse has access to that, and the consumer and the clinician are collaborating on the care, and I think we're likely going to see a lot more of that, especially as monitoring equipment becomes more effective, better cost, and so forth. So yes, certainly a lot of possibilities here what to pick. You mentioned the build versus buy and reliance on your primary EHR vendor. Just laying out, some of the options here. Build it yourself, rely on your primary vendor, or possibly go with a third party. And there are certainly hundreds, if not thousands, of companies that are out there looking to help you build stuff. And with FHIR coming along now as an interoperability standard, a lot of these third parties have this hope that they're going to be able to tap into your EHR data and build you all kinds of great stuff that your primary vendor may not have either in the roadmap, or it's not going to happen soon enough. So as the size hospital you are and the vendor you're working with, how did you go about making some decisions about building something yourself, or going with your primary vendor, or even going with some third party to help you do it?
Well, I think I mentioned, obviously, the ER project that we had that really ended up becoming a big learning experience for us in terms of build versus buy. We did recognize that there's a lot we don't know, and that if we were going to build, we'd have to probably staff up with people who really had some deep expertise in the mobile arena, whether it's app development or whether it's actually the technical side of understanding how to connect those devices to your network effectively, et cetera. And we had to make some decisions about what we were going to do in terms of consumer provided devices or the BYOD type stuff versus issued devices that may be cleaned of all of the bloatware that exists on pure consumer devices. But really, we're taking it on a case-by-case basis. It depends on what the need is. So on one end, our diabetes center has been very interested in managing larger populations of diabetics, and we've been working with them to evaluate a couple of third-party tools out there, and are nearing, I think, a pilot with a vendor in that space where we're going to look at managing populations of diabetics using Bluetooth enabled glucometers and apps that then tie back to the clinicians. But one of the things that's most interesting for us in this is also the aspect of the culture change / workflow assessment that has to be done, because just having the ability to collect that data and present it in sort of an independent third-party app doesn't necessarily fit into the clinician's overall workflow with everything else they're doing. And what we're trying to figure out now is how you integrate that into the overall clinical workflow, and that's not something we necessarily have a great answer on. Most of the solutions, like this diabetic tracking initiative, are really just kind of handled as one-offs. It's not integrated into our EMR at all. It's sort of managed by a clinician who's then driving that manually, effectively behind the scenes in terms of interventions and other things. So our goal is to look for ways to begin to tie that all in ultimately to the primary vendor. And we hope that standards like FHIR are going to help us tie that stuff in. But right now, there's not a lot, obviously, there's not a lot that's happening in the FHIR space that we can go to as a community hospital without sort of a deep bench on this. There are other health systems that are doing stuff with FHIR and doing some interesting stuff, but not much has been commercialized that we've been able to see yet.
Yeah, I'm thinking of how the EHR market now is, I think you could certainly say mature, or maybe even past that, whereas the mobile market is still relatively early stage. There were organizations that tried to build their own EHRs, years ago, and there may be a couple of holdouts, but, Partners or Intermountain or many of these now have all decided to move over to commercial EHR vendors. When it comes to mobility, there's still, I think, this temptation to say, well, we can build this ourselves, especially if your Epics or Cerners or other EHR vendors aren't moving as fast as you'd like, or the particular kind of capability that you'd like. But what we found found when we talked to many of these large organizations who could build a lot of this stuff themselves, even in this mobile space, they were often looking to the primary vendor first or some third party to build it for them rather than try to do it themselves, because there's frankly just too many challenges to keeping your apps updated, adding new features, dealing with regulations, supporting these. The guys who like to write this stuff are not always the guys who want to answer the phone and answer questions about how to fix it. So I think there's definitely a trend more towards the buy, and the possibility for third parties to step in here and supplement what the primary vendor is offering, I think is promising. But very few organizations, especially smaller organizations, can try to build any of this stuff themselves these days, however tempting it may seem.
I would agree with that. I think at this point, really, the health systems are going to end up playing general contractor a little bit and looking at point solutions and trying to find ways ultimately to tie them together. But sometimes you don't need to. I mean, some of these point solutions are perfectly fine existing in their own vacuum, kind of.
Yeah. All right, so moving on to this next big piece, the mobile deployment. Looking at previous concerns here, it wasn't that many years ago we were describing to people what mobile device management was, or mobile application management. Not everybody knew what BYOD stood for, and that the only devices you might see that weren't Microsoft were iOS devices. Now we're seeing Android coming on much more strongly. People are starting to focus more on not just do we have any kind of mobile policy, but is it more integrated, less concerned about wireless coverage now, and more about security and so forth. So as you've gone to deploy, you mentioned your communications app, what were some of the shifting concerns as you move from those old days of just putting infrastructure in place to now actually making it work well together and ensure that it's secure?
Well, we were challenged initially by trying to decide sort of iOS versus Android versus Windows, and obviously the Microsoft-based solutions just have struggled to get sort of traction on the mobile side. And really, it's a matter of Apple versus Android. So what we were trying to do is move away from stuff that relied as heavily on specific devices as we would perhaps try and drive folks to web-based, web-hosted mobile applications. For some things that worked well, but for other things like, let's say, our VoIP tool, we were using Cisco's Jabber, so we had to use the Jabber version for iOS or for Android, depending on which device we were rolling forward with. We initially made a decision that we were going to issue the devices ourselves and went with an all-Android strategy, but we got a lot of pushback, especially from physicians, and had to quickly back away from just a hospital-issued device to a BYO kind of strategy, and also for a variety of other reasons began to discover there were limitations with some of the devices that we had deployed in terms of sound quality and a bunch of other things. So we ended up supporting a wider range of devices than we anticipated, and ultimately learned that we don't want to do too much on the device itself. We'd rather push them to a mobile-enabled site that they can then, access and process information there remotely and just use the device as the access mechanism, not as the processing mechanism.
Yeah, and then on the MDM front, have you been happy with the capability that you've got there? Is it able to segregate personal from business for your users? And are you supporting more of a BYOD now? Or do you still find, especially now with all these security concerns, that you really got to lock this down and really limit what people can do?
We are supporting more of a BYOD, particularly for the clinicians, in terms of employed folks within the hospital, whether that's administrative folks or others. Those we're utilizing hospital-issued devices to have a slightly higher level of control. We do have a lot of concern around security. We're using AirWatch, and we feel that it's It's giving us the control we need. It's giving us the ability to segregate the business versus the personal, if you will. But still, it's an area we're learning more and more about. And obviously, with all that's going on with security breaches and things like that, we're trying to stay as up on all of it as possible to make sure that we keep current with the possible threats in that area.
Yeah, when we were talking to organizations about security and management, it seems like if you're kind of turning your physicians and your departments loose to develop what they think is valuable or go in directions they want, you don't want that to become the next big mess. Rather than stifle their innovation, say, all right, we're going to let you build what you like, but you're going to have to bring it back to some type of a mobile center of excellence, or it's going to have to go through some type of a security review before it can be deployed. So I think if there isn't a centralization of development, there at least has to be some centralization of deployment and security.
I would agree. There should be a standard or two in how things are being developed. We, as a community hospital, we have a little bit more control over some of that. Obviously, in larger academic medical centers or health systems, you're going to have a lot more independent activity going on. And if you can publish a broader kind of guideline or standard around mobile development, mobile use, and some minimum expectations, then it can help streamline how you deploy things in the infrastructure and certainly help to keep things more secure.
Okay, so I stepped on to the next segment here on adoption and measurement. So you got your strategy, you've decided what use cases to go for, you've made a build versus buy decision, you've put some infrastructure in place to manage it all. Now you got to get people to use the stuff, and you got to hopefully measure to see that you're getting some value. I listed there on the left side a number of strategies that we've seen organizations use to promote adoption. Incentives versus penalties, right? We'll give you X if you use it, or possibly at some point, if you don't use it, you'll be penalized in some way. Genius bars, sort of similar to an Apple store where people can walk in and get advice, not necessarily have to pay for it. The use of super users, promotional events, pizza. Were there any of these on the left side that you have tried or you're thinking about employing?
We've tried almost all of them, and they all work in different ways and at different levels and with different audiences. So a lot of it is understanding who it is you're trying to get excited and what mix of these you need to employ. In fact, our IT team here at JFK is launching a Meet the Geek kind of session, which is sort of a mix of I would call it a mix of the Genius Bar versus the super user kind of a thing, where we're going out there and having these specific opportunities to have IT folks in like the employee cafeteria and places like that to answer a lot of generic questions around not just mobile but other things, but mobility is a piece of that. The challenge I think we've had really is there's a couple of things that have to happen in terms of getting people excited, and part of it is leadership's ownership over driving some of these mobile initiatives, and truthfully the fact of whether they're delivering perceived value or not. And I'm not talking about the right side of the slide where we're measuring specific value to the organization, but are the users perceiving value? I mean, one of the things you and I talk a lot about, Ken, is sort of the Amazon experience. I'm a big Amazon Prime user. It's one of the things that kind of drove me to engage with you on all of this. And the fact of the matter is, if I look at pure metrics, I'm probably paying more for a lot of the goods I'm purchasing now, but the convenience factor is so much more important to me that I'm just hooked on this, and I'm a heavy user of Amazon. And the question for us is, how do we begin to take that kind of mindset out there to our customers with these solutions. And right now, when you look at things like secure texting as a very simple mobile solution, most of the physicians feel it's clunkier. Why? Because it's a separate texting solution. It's not what they do normally in terms of texting their family and friends. They have to go to a separate place and enter a separate login or identifier to authenticate into it, and then they can text and do stuff. And there's reasons for it, HIPAA compliance and a bunch of other stuff, but it's not making their life necessarily easier. It might be protecting them, but they don't feel that same value proposition. And that's part of our challenge with looking at these tools and these apps and other mobile kind of solutions we want to deliver, and how do we get some of that excitement? You say get people excited. How do we really excite them around some of these?
Well, there on the right, we've got some possible ways of determining value, and some of them are more operational, like how many people are actually carrying a smartphone or have an application downloaded. Then you can move up to things like satisfaction, do they like it, up to results, which could be something very measurable, like how long does somebody have to wait for something, or even clinical outcomes, or financial outcomes. Have you attempted to measure any of your initiatives, and you're finding some value from this, or is the jury still out for you?
So on things that are specifically clinically based, like as an example, this diabetes solution, we haven't rolled it out yet, but the plan there is to measure actual outcomes and look at the A1C values and other things for that population and see how we're going to impact it. On things like the secure texting, we've struggled with how to measure the utilization of it, because I can measure how many people downloaded the app, or I can measure how many people sent a secure text, but that doesn't necessarily translate into specific value. And how do I know that if they sent 10 texts that month, that was really the universe of texts, or did they send 20 through their normal unsecured texting method, and did I expose myself or the organization to risk because they aren't using the compliant pathway? So some things are harder to measure than other things, but our goal is with any of these projects, and frankly not just for mobile projects, but for most of us, any kind of IT initiatives, you're looking to have some tangible measures to show value for the investment. Ken, you there? I think I'm losing you.
No, I had to slide my mute button in the right direction. So as we go to our last slide here, looking to the future, I have, how full will your parking lot be? And this came about for two reasons. One, when I came to visit you just recently, I couldn't park. You're a modest-sized facility and in a pretty rural area, at least for New Jersey. But I drove around for a long time. I couldn't even park legally. Even in front of a fire, there was nothing. And I was just recently at a digital health conference in New York, and a couple of the very prominent health system folks got up in front of the room, and they said, look, if you think that you're going to disintermediate our health system and our hospital, he goes, forget it, And I think it's hard to appreciate how our industry really could be changing in any significant way, where these pillars of our community right there in the most prime real estate, the biggest building on the hill, for example, could ever not be there or have that same prominence. But then you mentioned shopping with Amazon or any of these other leading companies and where they're taking cars or devices and so forth. It does seem like we really have to wake up to this idea that things could really change. And what are some of the thoughts you have of how organizations should see that this is what's coming and take steps to deal with it?
Well, I certainly think that mobile is a major disruptor. It's disrupted other industries, obviously retail. I think it's disrupting banking. It's disrupting most industries, travel, and not necessarily always in the fully convenient ways that we've been accustomed to it, but it is changing the dynamic with how we are interacting with a variety of our service-type organizations. And I think that we're going to see that happen in healthcare Whether the providers are driving it or along for the ride or get run over by it, I think is a great question. I do believe that the providers, much like the large EMR vendors and other system vendors out there, have the risk of becoming these slow-moving behemoths. And if we're not nimble enough, you're going to see these small telehealth companies and others coming up and beginning to eat your lunch, or you're going to see the Walgreens and CVS's with their Minute Clinic concepts come in and begin to eke away at some of your core primary care type business, and you're going to have to make hard decisions about whether you give up that ground or you partner with these people and hold on to the rest of kind of your business that they can't deliver to. But over time, we've seen, when you look at the Internet of Things concept, the range of devices that are out there right now, diagnostic level devices, the cost of which are dropping dramatically. What's that going to do to lab services, which is a huge profit center for hospitals right now? What's it going to do to diagnostic radiology and other services, which again are huge profit centers? These things are all being moved to the home. Sleep studies, things like that. You know, we as providers have to be on top of this and ready to react. Otherwise, we're going to see some of our key revenue centers really begin to dry up, and I don't know whether we can, many of us will be able to react in time to that.
Yeah, okay. All right, well, that's the end of the prepared slides that we have. Turn it back over to Anthony to address any questions that may have come in.
Very good, very good. Thank you, Ken, and thank you, Neal. Great presentation and a lot of stuff to think about. There's some contact information for the gentlemen if you had any questions you wanted to reach out to them privately. But now we are going to have our Q&A. We have a few minutes left. So if you have any questions you'd like to get their thoughts on, send them in the Q&A box. Leave the default set to all panelists, and we'll take a look. Let's get started. Neal, let me ask you, as a CIO, talk about the difference between being proactive and reactive in this space. Obviously, you mentioned you have clinicians and you have patients that have expectations that are derived from, you know, the outside world, Amazon and all these kind of things. They have certain expectations. You can be very reactive and just wait till you're asked to provide things, or why can't we do this, and then meet those specific needs. And you can be proactive and try and get ahead of things. You mentioned how far behind healthcare is. So just your thoughts on those two dynamics.
So I think it is, there's a real challenge for us there in terms of trying to be proactive and meet the needs of the consumers or customers. I think one of the first challenges we have, though, is really fully understanding what those needs are. We are making a lot of big assumptions to say, hey, our population really wants to schedule online or would like to have a telehealth visit. And we don't necessarily know that for a fact, and it really could vary widely depending on the population you serve, et cetera. What we need to do better is understand the makeup of our customers and what are the kind of services they're clamoring for. Just because I'm an Amazon junkie doesn't mean that a majority of other people are. But I think we also have to understand that this curve of demand is shifting, it's bending, and we may have to be willing to get into it early, because part of the process here is teaching the consumers that there is a better or easier way that they just may not have ever thought of or be used to. And so there's a balance there. How do you figure out how to get in early enough so it's not too early, and how do you make sure you're delivering value to meet the needs of that population?
Yeah, Ken, to Neal's point, it's the whole, the Steve Jobs thing. So you've got the element of Steve Jobs saying people don't know what they want until you make it for them, and that's the revolutionary idea. I'm not going to wait till customers tell me what they want. I'm going to give them something they never dreamed of. But then there's the more realistic human approach. We're not all superheroes, which is we need that feedback. So do you recommend getting surveys out there to your clinician and patient population to find out what they want, or do you try and do a Steve Jobs and divine and come up with the things that they don't even know they want yet?
Yeah, I think it's both. I just recently needed to get a medical form filled out for my son who's going to a summer camp, and the health system is about 20 minutes away. And I said, could I email you this document? Oh, no, we can't accept anything via email. And so they said, could you fax it to us? And of course, I don't even have a fax machine anymore, let alone a landline. So now they just called me today to say that the document is ready. And I'm like, and they said, well, you want to come in and pick it up? It's like, no, can't you? I literally said, can you mail it to me? That was the best they could do. That's really, far behind our experience with other areas. So it's not like we're not giving them feedback along the way. And I think they're receiving a lot of it. The status quo is really what's been the limiting factor. And if they feel like, they're the big game in town, where are you going to go? Unless you're in a competitive market, it's hard to really see that pressure. And then sometimes it's not until your clients leave you that you realize you should have done something. And we've seen this, right? The old guard never seems to carry through.
I would argue that Uber is a great example of that in the taxi industry, right? I mean, now that you've kind of democratized the ability to give people a ride, all of a sudden there's this competition that nobody foresaw. And I think we're going to see similar things with physicians, frankly, where these folks who don't want to establish a large practice or have overhead and everything, docs are probably going to say, hey, I'm going to have a laptop and a car and a medicine bag and an app. And you know what? I don't even need to take insurance. I'll take the $50 that you pay me by credit card, and I'll have my Foursquare on my iPhone, and you just swipe the card, and we're done. And I think that's coming, and that's going to disrupt a lot of the traditional practices.
All right, question from the audience, and you touched on this a bit, but how do you determine when it's a buy or a build? I guess your solution or your mobile approach, buy versus build.
I'll just say that even some of the large organizations I talked to had a tremendous amount of experience building applications themselves or customizing. Montefiore was an example. Providence, another one. They have basically said, we're going to have people build this for us. We're going to provide them the specs, or we're going to subcontract for this. We just don't want to be in the app business. So for me, even for the big organizations, it's gone in that direction. And for smaller organizations, I don't really see that they have an alternative for a lot of the reasons that we mentioned before. Neal, I think you had pretty much the same conclusion.
Yeah, I think a lot of it really is buy. I mean, there are some things that you might want to be able to look at building simple apps and things like that you can roll out to populations. But by and large, it's a question of whether your organization's philosophy is around application building, mobile or not, versus buying packaged and proven applications that are out there.
Very good. All right, last question. I'm going to let you go real quick, Neal. Again, about the expectations people are coming into the health system with versus where the health systems are. What sort of reality check can you provide to people in terms of, hey, listen, we're trying to move there, but here's where we are now. I mean, do you have to have some tough conversations and get people just to the reality of where health systems are today?
It's an interesting question, Anthony. I think in some ways we're challenged by the fact that the model is going to be disrupted, and we need to figure out how we can reinvent ourselves while not going out of business in the process.
Right.
One of the things I always struggle with when I give presentations internally about mobile and trying to be more Amazon or Uber-like is we can't compete on the level of investment that Amazon puts into technology. Not when, as a community hospital, we spend 3.5 or 4% of our revenue on IT overall, let alone mobile-based solutions. So we've got to be smart about this. We've got to understand what the upcoming threats are, and I think strategically, the organizations need to be developing longer-term plans around those things. And that does involve a lot of clinician engagement because they're the ones who are seeing some of this coming up in their journals and other things in terms of these diagnostic tools and other stuff. Regulatory, I think, restrictions and limitations have kind of kept some of that stuff at bay, but slowly you're going to see that stuff loosen up, and I think the drive to value-based care is getting stronger and stronger. Obviously, with the new administration, it's hard to say what might change there, but I think from a bipartisan standpoint, everybody believes costs for healthcare must come down. And in order to do that, we've got to leverage some of these technologies, such as telehealth and such as some of these remote monitoring and other tools that today we don't support from either an operational or regulatory standpoint. So there's multiple factors coming, but at some point those barriers are going to be taken down, and we as hospitals, if we want to survive, have to be ready to ride that bandwagon, or in fact even promote taking those barriers down so we can function in that new market or new kind of optimized world.
Ken, any final thoughts?
Oh, well, I think it's easy for the incumbents to say, oh, to change things. It's so complicated. There's so many barriers. Let's keep doing things the way we've done them. And it's not until somebody comes along with this innovative disruption, like Uber, for example. And you could have come up with many, many reasons why Uber wouldn't have worked. The danger and lack of, who the driver is, and on and on and on. But sure enough, it turns out to be a much better approach where most people win. I think that we're in that position in healthcare. We're so concerned about all the complexity and the regulation and what about HIPAA and whatever, that it's getting in the way of us actually getting some simple stuff done that would make a big difference, like being able to easily communicate with our caregivers or access medical forms or lab tests and things of that sort. So we can't let the complexity of this get in the way of being able to make simple things possible, and looking at that convenience factor, which in our world seems to be becoming more and more important.
Very good. All right, we're going to leave it there for today. When you close out your WebEx window, you'll be taken to a post-event survey. If you could take a moment and answer that, we'd appreciate it. I want to thank our speakers, Neal Ganguly and Ken Kleinberg, very much for putting together this valuable presentation. For those of you who have continuing education interest in today's event, attending our events gets you 1 CEU for the CHIME CHCIO program, so let CHIME know you were here, and if you've asked us to do so, we will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when this recording has been posted to our YouTube channel. If you'd like us to produce a webinar for you, you can contact Nancy Wilcox for more information. And you can go to our website to view our upcoming schedule. So with that, I want to again thank Neal and Ken and our audience. Everybody have a wonderful day. Thank you.